Hey everyone, welcome to today's Explainer. We are doing a completely comprehensive clinical teardown of encephaloceles. And I mean comprehensive. We're going through this point by point, breaking down every single facet so clearly that you won't even need to open the book to grasp the concepts. Whether you're reviewing for boards or just trying to solidify your clinical knowledge, we're going to turn dense pathology into crystal clear understanding. Let's get right into it. Here's our roadmap for today to make sure we don't skip a single detail. 1. Definitions and general info. 2. The classification system. 3. A basal encephalocele deep dive. 4. Etiology theories. 5. Treatment approaches. And finally, 6. Prognoses and outcomes.
All right, let's jump straight into Section 1, Definitions and General Information.
First up, we have to build our foundation by defining cranium bifidium. Simply put, this is a defect where the cranial bone completely fails to fuse. It almost always happens right in the midline, and you're going to see it most commonly in the occipital region. This specific anatomical opening is exactly what sets the stage for the herniations we're about to talk about.
Now, here's a massive distinction you absolutely have to know for clinical practice. If only the meninges and the cerebrospinal fluid herniate through that bony defect, we call it a meningocele. But if you have actual cerebral tissue protruding alongside the meninges and CSF, that upgrades the diagnosis to an encephalocele, which is also known as a cephalocele. That single anatomical difference literally changes everything about how the patient presents and how you treat them.
To put things into perspective, encephaloceles are actually quite rare, especially when you compare them to spinal defects. For every 5 cases of spinal myelomeningioles a clinician might see, there's only 1 observed case of an encephalocele. So having intracranial structures extending outside the normal confines of the skull is comparatively pretty uncommon.
Okay, pay close attention to this one because it's a huge clinical warning sign. If you observe a nasal polypoid mass in a newborn, your immediate baseline reflex must be to consider it an encephalocele until proven otherwise. Misdiagnosing that mass as just a simple nasal polyp can lead to some truly catastrophic surgical errors, as we'll see in a bit.
Moving right along to Section 2, the classification system developed by Suwanwela and Suwanwela.
This table gives us an awesome macro view of the 5 main locations and their relative frequencies before we slice into the specific subvariants. First, we have occipital, which frequently involves vascular structures. Second is the cranial vault, and that makes up about 80% of all cases in the Western Hemisphere. Third is frontoethmoidal, also called sincipital, representing 15% of cases. Fourth, we have the incredibly rare basal group at just 1.5%. And finally, posterior fossa encephaloceles, which usually contains cerebellar tissue and a ventricular component. Let's zoom in on the cranial vault, since it makes up that huge 80% chunk of Western cases. There are 5 distinct developmental subregions here. We've got interfrontal, anterior fontanelle, interparietal, which actually, much like the occipital class, often involves vascular structures, temporal, and finally, posterior fontanelle. Knowing these specific locations is absolutely crucial because the location dictates your surgical approach and the specific risks involved. Building on that, let's look at the frontoethmoidal or sincipital group. Notice how all 3 of these subtypes share a really specific common trait. They have an external opening going straight into the face. The nasofrontal subtype features an external defect right in the nasion. The nasoethmoidal has a defect between the nasal bone and nasal cartilage. And the nasoorbital involves a defect in the anteroinferior portion of the medial orbital wall. Then we have the basal subtypes. Though they're super rare, only 1.5% of cases, these 4 involve incredibly complex internal protrusions. The transethmoidal protrudes directly into the nasal cavity through a defect in the cribriform plate. The sphenoethmoidal pushes into the posterior nasal cavity. Transphenoidal herniates into the sphenoid sinus or nasopharynx via a patent craniopharyngeal canal, which you might know as the foramen cecum. And lastly, the frontosphenoidal or sphenoorbital pushes right into the orbit through the superior orbital fissure.
That brings us to Section 3, a deep dive specifically into basal encephaloceles.
Why do they get their own section? Because unlike everything we just covered, a basal encephalocele is basically hidden from view. It is literally the only group in this entire classification system that does not produce a visible soft tissue mass. It's a total diagnostic chameleon.
So if there's no visible mass, how on earth do you spot it? You've got to look for a specific cluster of clues. It might present stealthily as a CSF leak or as recurrent meningitis. You also need to actively hunt for associated craniofacial deformities, things like a cleft lip or a bifid nose. Optic issues are super common here too, like optic nerve dysplasia, coloboma, and microphthalmia, alongside potential hypothalamic pituitary dysfunction. It's a really complex web of symptoms.
Before we move on, we have to touch on a very severe, specific presentation related to these defects, called enencephaly. This is characterized by defects around the foramen magnum, accompanied by rachyschissus and retrocallus. It carries a remarkably grim prognosis, guys. Most infants with this condition are stillborn, though the literature does note some very exceptional cases surviving up to age 17.
Section 4. Theories of etiology. How do these defects even form?
The medical literature essentially splits into a classic chicken and egg embryology debate. We have two main theories. Theory 1 suggests there's an arrested closure of the normal confining tissue, which then passively just allows the brain and meninges to herniate through that persistent opening. Theory 2, on the flip side, argues that an early aggressive outgrowth of neural tissue actively blocks and prevents the normal closure of the cranial coverings.
All right, Section 5. Let's talk about clinical intervention and surgical treatment approaches.
For occipital cases, you're looking at direct surgical excision of the sac and its contents. But cutting it out is only half the battle, right? It demands an absolutely watertight dural closure to prevent postoperative leaks. On top of that, the surgeon has to constantly anticipate the presence of those entangled vascular structures we mentioned earlier. And because hydrocephalus is so often present alongside the encephalocele, the surgical team has to be ready to treat that as a totally separate parallel issue.
But wait, consider this a massive clinical stop sign. Remember how we said a newborn with a nasal polypoid mass has to be treated as an encephalocele? This is exactly why. A standard transnasal approach to a basal encephalocele, even if you're just going in for a quick biopsy, can be fraught with catastrophic complications. We're talking intracranial hemorrhage, meningitis, or a persistent CSF leak.
So, to avoid those catastrophic risks, what do surgeons actually do? They rely on a highly coordinated two-step combined approach. The standard treatment for a basal encephalocele almost always begins with an intracranial approach, where they amputate the extracranial mass from above. Only after that area is completely secured do they follow up with a combined transnasal approach to safely resolve the rest of the defect.
Finally, we reach Section 6, Prognosis and Patient Outcomes.
When it comes to occipital defects, we can largely predict outcomes based on structural severity. Naturally, the prognosis is inherently better if you're just dealing with an occipital meningocele rather than a true encephalocele. But things worsen significantly if a large amount of cerebral tissue is trapped in the sac, if the ventricles extend directly into the sac, or if there's accompanying hydrocephalus. Basically, the more complex the herniation, the steeper the uphill battle for the patient. We're going to leave you with a pretty sobering statistic today. Fewer than 5% of infants with an encephalocele will go on to develop normally. It really underscores the immense gravity of this diagnosis, and it drives home exactly why understanding every single anatomical detail, every classification, and every surgical caution we just went through is absolutely critical. When you're faced with a condition where the margin of error is virtually zero, you really have to wonder, how will future advancements in neural tube defect prevention and fetal surgery eventually help us rewrite this devastating statistic? Keep studying, keep asking those big questions, and I'll see you in the next explainer.